So today we are jumping straight into a really fascinating deep dive.
Yeah, it's a great one.
And we're basing this on a medical lecture video we found from the YouTube channel Gatamukala S. Raju.
Right.
The specific video is titled HCC 1475-20 Lugol's Iodine. And it details this diagnostic technique that honestly feels like something pulled directly out of a spy novel.
It really does, yeah.
I want you to imagine just for a second that you are searching for a tiny, completely invisible thread. And you have to find it inside this dark, incredibly narrow, collapsed tunnel.
A very hostile environment.
Exactly. And you can't see this thread with the naked eye because it blends in perfectly with the surrounding environment. So how do you find what you fundamentally cannot see?
Right, that's the big question.
You might assume the answer involves, I don't know, $1 billion medical laser or some highly advanced AI imaging system. But the secret weapon Dr. Raju outlines in his lecture is actually a simple centuries-old mixture of iodine, potassium iodide, and water.
It's amazing. The elegance of this approach, it really lies entirely in its reliance on fundamental biology rather than, complex technology.
Right.
We are analyzing the application of Lugol's iodine, which is a chemical solution developed back in the early 1800s.
Wow, that long ago.
Yeah. It predates modern endoscopy by well over a century, yet it remains one of our most effective tools for uncovering these microscopic, precancerous changes in the human body.
So it's the exact same basic iodine you might associate with like a high school chemistry lab or treating a scraped knee.
Exactly the same stuff.
But it's being used as a chemical blacklight. So our mission for this deep dive is to understand exactly how doctors are deploying this rudimentary solution to map out hidden squamous cell cancers, specifically within the esophagus.
Right.
We are looking at an absolute masterclass in how a profound understanding of cellular behavior can just completely outmaneuver a lethal disease.
It really is. And to appreciate how this works, we first have to look at the physical mechanics of the procedure itself.
Okay, lay it out for us.
So we're dealing with an endoscopy. That's where a flexible tube equipped with a camera is navigated down the throat and into the esophagus.
Right. Most people are vaguely familiar with that.
Yeah.
Yeah.
And the physician is in there hunting for dysplasia,
Wits.
those early precancerous cellular mutations. The problem is, under the standard white light of the endoscope camera, these mutated cells are virtually indistinguishable from the healthy mucosal lining.
Because they're perfectly camouflaged.
Exactly. They look completely normal.
And the esophagus isn't just some rigid pipe either, right? I mean, it's a muscular tube that is mostly collapsed when you aren't actively swallowing food.
Yeah, it's a very tight dynamic space.
So the doctor is navigating this really difficult terrain. And once they get into position, they introduce a specialized spray catheter. And they prime it with just a standard 20 cc syringe loaded with that Lugol's iodine solution. But the technique Dr. Raju emphasizes in the video is highly specific.
Very specific.
They don't just spray the solution arbitrarily as they go down. They navigate all the way to the bottom first, right?
All right, the spatial awareness required here is critical. The physician advances the endoscope all the way to the distal end of the esophagus.
So right down by the stomach.
Exactly, right before the junction with the stomach. And they begin spraying the iodine solution only as they slowly withdraw the catheter proximally.
Meaning they move back up toward the top of the throat.
Yes, exactly. Moving upward while spraying.
Visualizing that physical motion, I mean, it makes complete sense. It's the exact same principle as painting a floor.
Oh, that's a good way to put it.
You always start at the furthest corner of the room and work your way backward toward the door. Because if you start at the door and paint your way in, you just trap yourself.
You'd be standing in wet paint, yeah.
Right. So by starting at the distal end and pulling up, the physician ensures they're applying this even controlled coat to the esophageal walls. Without blindly pushing a pool of liquid down into areas they aren't actively viewing, it basically guarantees a clean field of vision as they retreat.
Exactly. And as that even coat of iodine interacts with the tissue, the visual transformation is, well, it's rapid and striking.
What does it look like?
If you're watching the monitor, healthy esophageal tissue immediately reacts to the solution by turning a stark, dark brown color.
Just instantly.
Pretty much. The entire inner lining of that tunnel essentially stains itself brown.
But the objective is to find the diseased cells, not the healthy ones.
Right.
And the diseased tissue, it fails to undergo this transformation.
It does.
The abnormal areas, whether they're dysplastic, actively cancerous, or even just heavily inflamed, they remain completely unstained. They stay pale.
Yeah.
So you end up looking at this dark brown sea interrupted by these highly visible pale islands of dangerous tissue.
That stark contrast is exactly what guides the physician's biopsy forceps. But to understand the why behind this visual phenomenon, like why it actually happens, we have to look much closer at the microscopic landscape of the esophagus.
Okay, let's zoom in.
Human anatomy dictates that roughly 90 to 95% of the esophageal lining is composed of squamous epithelium.
Squamous meaning?
These are flat, tightly packed, scale-like cells. They form a durable protective barrier against the friction of swallowing food.
Because that's a high-friction environment.
Very high. But that biological makeup changes right at the very end of the tunnel.
Right. The final centimeter or so of the esophagus, just before it enters the highly acidic environment of the stomach, transitions into columnar epithelium. And that distinct border where those two cell types meet, that's known as the Z-line, right?
Yes, the Z-line or the squamous-columnar junction.
Okay.
For our purposes, the really vital characteristic of those flat squamous cells making up the vast majority of the esophagus is their metabolic payload.
What do you mean by payload?
They are absolutely loaded with glycogen.
So we are relying on the cell's internal energy reserves.
One sec.
Glycogen being, stored complex carbohydrates. The squamous cells hoard these carbohydrates to maintain their protective function.
Right.
And this is where the chemistry of Lugol's iodine actually comes into play. It is an absorptive stain.
Yes.
The iodine molecules are specifically seeking out and reacting with the glycogen inside those cells. So if you picture the cellular glycogen as a highly dense molecular sponge,
That's a perfect analogy.
it just absorbs the iodine solution. And the chemical binding of the iodine and the glycogen is what produces that distinct dark brown pigmentation.
Yes, the presence of the brown stain is a direct visual confirmation of rich glycogen stores.
Okay.
Now, think about what happens when a squamous cell experiences severe trauma or some sort of genetic mutation.
It breaks down.
Right. When these cells are damaged by chronic inflammation, or when their DNA begins to mutate into a precancerous state, their internal metabolic machinery is fundamentally disrupted.
Meaning they can't function normally?
Exactly. And one of the very first physiological changes during this unhealthy transformation is their rapid depletion of their glycogen reserves.
They lose their metabolic payload entirely.
Yep.
And no glycogen means the cell no longer has that molecular sponge.
The fluid simply washes over those damaged, mutating cells without any chemical reaction taking place.
Wow.
Without the glycogen to bind to, there's simply no brown pigmentation.
This completely inverts my initial assumption about how a medical stain should work.
How so?
Well, we aren't actually staining the cancer. We are staining literally everything except the cancer.
Right, yeah.
It is this brilliant process of elimination. You are creating an inverse map where the blank spots are the actual target.
An inverse map is the perfect way to conceptualize it.
It makes so much sense.
Healthy squamous epithelium maintains abundant glycogen so it stains brown. Diseased or mutating squamous epithelium is depleted of glycogen so it stays pale. It provides an immediate, highly localized topographical map indicating exactly where the mucosal lining is failing.
It's incredible.
Without this simple chemical interaction, identifying those microscopic dysplastic changes would be practically mathematically improbable.
Yeah.
It'd be like searching a massive grid for a single structural flaw in complete darkness.
So if this rudimentary chemical test is so incredibly effective at highlighting these invisible danger zones, it really begs a broader question.
Which is?
Why not use it on everyone? I mean, logic would suggest we use this iodine stain as a universal screening tool during routine checkups, but we don't.
We don't. And that brings us to the core philosophy of medical screening.
Okay.
The mathematical risk-reward ratio must justify the intervention. You only subject a population to an invasive procedure if their statistical probability of developing the specific disease outweighs the physical risks and the financial costs of the screening itself.
Right. You don't do a colonoscopy for a stubbed toe.
Exactly. An esophageal squamous cell cancer is not uniformly distributed across the global population. Dr. Raju's lecture outlines highly specific, high-risk populations where the probability of this cancer developing is so elevated that this inverse map becomes an absolute necessity.
Let's examine those criteria then. Who actually qualifies for this aggressive screening? The source material points out specific demographic risk factors first, right?
It does. Historical and genetic data show that populations from specific regions in Asia and Africa experience disproportionately high rates of esophageal squamous cell carcinoma.
Okay.
For individuals of Japanese and Korean descent, the clinical guidelines strongly recommend initiating this specific type of chromoendoscopy screening beginning at age 40.
Wow, age 40.
Oh, no.
But the demographic data is only one facet of the risk profile. The patient's underlying medical history drastically alters that math.
Not very much, though.
The lecture highlights patients suffering from a condition called achalasia cardia,
Right.
which is a severe motility disorder. The nerves controlling the esophagus basically degrade, meaning the lower esophageal sphincter, that's the muscular valve at the bottom, it fails to relax and open properly to let food pass into the stomach.
And the biological consequence of that nerve failure is profound stasis.
Meaning things just sit there.
Yes. Food and liquids back up and pool in the esophagus for extended periods.
Oh, that sounds awful.
It is. This stagnant material ferments and creates a highly toxic, chronically inflamed environment.
And chronic inflammation is the absolute enemy of cellular integrity.
Always.
That constant daily trauma to the squamous lining is what damages the cells and depletes their glycogen over time.
You've got it. The continuous cycle of destruction and inadequate repair in an achalasia patient creates the perfect breeding ground for cellular mutation.
Makes sense.
The cancer risk escalates so significantly that the guidelines actually mandate action.
Like a strict timeline.
Yes. If a patient has been living with achalasia for 10 to 15 years, they cross a statistical threshold where they require this Lugol's iodine screening annually.
Every single year.
Yes.
The lecture also dives into caustic injury survivors, which honestly introduces a terrifying concept regarding cellular memory.
It is terrifying.
We are talking about individuals who suffered severe chemical burns to their esophageal lining, perhaps from accidentally ingesting a harsh alkaline cleaning chemical, like lye.
Right. The initial trauma from a caustic ingestion involves coagulative or liquefactive necrosis.
That sounds intense.
It's the rapid death of the tissue.
Oh, wow.
The body responds by healing the area with dense fibrotic scar tissue. But the risk doesn't end when the burn heals.
That's the crazy part.
Even 10 to 20 years after the initial chemical exposure, the cells that are frantically turning over in that hostile, scarred environment remain at a highly elevated risk for replication errors.
So 2 whole decades later, the tissue still bears the biological memory of that burn.
Exactly.
It fails to store glycogen properly, mutating into squamous cell cancer.
Yeah.
Because of that, those survivors are placed on a screening schedule every 2 to 3 years.
That's right.
And following that logic of damaged tissue, it makes sense that previous cancer patients are also categorized as high risk. Specifically, individuals who have survived and completed therapy for head and neck squamous cell cancer.
Right, and that involves a concept known as field cancerization.
Field cancerization.
Yes. The squamous epithelium lining the mouth, the throat, and the esophagus. It's essentially one continuous biological tract.
Ah, okay.
If the genetic and environmental factors were severe enough to precipitate a squamous cell cancer in the head or neck, the neighboring tissue down the tract in the esophagus has likely been exposed to the exact same oncogenic pressures.
So it's all a shared neighborhood.
Exactly.
Yeah.
It is considered highly compromised territory.
Okay, but the most surprising high-risk category outlined in Dr. Raju's notes involves a very rare genetic condition known as tylosis.
Yes, tylosis.
This is where the interconnected nature of the human body becomes almost unbelievable to me.
It really is wild.
Tylosis is characterized by hyperkeratosis. Patients develop a severe thickening and darkened hyperpigmentation of the skin, specifically on the palms of their hands and the soles of their feet.
Right, and the systemic connection here is a stunning display of genetics.
How does that even work?
Well, the specific genetic mutation driving that abnormal keratinization on the hands and feet is inextricably linked to the mucosal integrity of the esophagus.
That is wild.
The presence of tylosis carries an astronomically high lifetime risk of developing esophageal squamous cell cancer.
Just because of that gene.
Yes. The correlation is so strong that patients presenting with this skin condition require incredibly aggressive internal surveillance.
Yeah. The lecture says they need 4 quadrant biopsies. The physician isn't just looking. They are physically sampling tissue from all 4 walls of the upper, middle, and distal esophagus every 1 to 3 years.
They have to be thorough.
Because your palms literally hold a genetic red flag, signaling a critical threat to your digestive tract.
It completely forces us to look at the body as a unified system rather than just, isolated organs.
Right.
And expanding on that unified biology, the principle of utilizing iodine to map glycogen-depleted squamous cells isn't restricted to the esophagus.
Oh, really?
Because the cellular mechanics are identical, Lugol's iodine is actually a primary diagnostic tool used globally for both cervical cancer screening and anal cancer screening.
I had no idea.
Yeah. The anatomical location changes, but the fundamental interaction between the absorptive stain and the cellular sponge remains exactly the same.
Okay, I want to pivot slightly and look at the reality of this procedure.
Sure.
Because injecting a chemical solution into a confined internal space cannot be a completely benign process.
No, it is not.
Lugol's iodine is highly effective, but it is not a gentle substance.
Not at all. You are looking at a serious procedural trade-off here. Lugol's iodine is a severe mucosal irritant.
Okay.
By introducing it to the esophagus, you are actively inducing a mild chemical burn to the very tissue you are trying to evaluate.
So it actually causes acute esophagitis.
Yes.
And if that liquid pools downward, you are looking at gastritis when it hits the stomach lining.
Exactly.
That cannot simply spray a harsh irritant and just leave it there.
You absolutely cannot. The endoscopist must employ rapid countermeasures to mitigate that collateral damage.
What kind of countermeasures?
Well, the moment the dye is applied and those pale islands of dysplastic tissue are visually identified and targeted for biopsy, the medical team immediately begins aggressively flushing the esophageal walls with water.
Just hosing it down.
Essentially, yes.
Yeah.
They utilize the endoscope to suction all the residual iodine and wash water out of the stomach cavity, actively minimizing the duration of the chemical exposure.
Man, it is an intense clinical balancing act.
It really is.
You are deploying a toxic irritant to unmask a lethal cancer and then racing the clock to evacuate that irritant before it inflicts its own long-term damage.
Exactly.
And that doesn't even factor in the immunological risks like hypersensitivity.
Right. Anaphylaxis is a catastrophic risk here.
Because some people are severely allergic to iodine.
Yes. Patients with any documented allergic reactions or hypersensitivity to iodine are strictly disqualified from this specific chromoendoscopy.
It's just off the table for them.
Completely.
Mm.
But beyond the chemical burns and the immune responses, the most immediate, life-threatening physical danger during the procedure involves basic plumbing and gravity.
We are talking about the aspiration risk.
Yes.
As we noted earlier, the esophagus is a narrow collapsed tube. It is not a holding tank designed for liquid capacity.
Exactly. When a physician rapidly introduces a volume of liquid into that confined space, there's a serious risk of displacement.
The fluid has to go somewhere.
Right. Furthermore, the patient is under sedation, meaning their natural gag and cough reflexes are chemically suppressed.
So they can't protect their own airway.
They can't. If that iodine solution backs up proximally into the throat, it can easily spill over the vocal cords and enter the lungs.
And pulling a highly irritating chemical fluid into the delicate alveoli of the lungs results in aspiration pneumonia.
Which can be fatal.
Right, so the lecture details the defensive driving required to prevent this.
Yes, the preventative measures are entirely mechanical.
What do I do?
First, the medical team elevates the head of the patient's bed. They're enlisting gravity to force the fluid downward toward the stomach.
Okay, that makes sense.
Second, as we discussed with the painting analogy, that specific technique of spraying from the distal end and pulling upward ensures the volume of fluid is being pushed away from the airway.
So pushing it down while pulling the camera up.
Precisely. And finally, the team maintains an active suction catheter positioned right at the patient's head, ready to instantly clear the airway at the very first sign of fluid backing up.
The mechanical precision required is immense. But there is one final, really fascinating physiological precaution Dr. Raju mentions that highlights how deeply an endoscopist must understand the entire human endocrine system before they spray this dye.
Oh, yes.
The thyroid connection.
This is a crucial one. The thyroid gland's primary function relies on the absorption of iodine from your bloodstream to synthesize essential hormones.
Right. Iodine is fuel for the thyroid.
Exactly. Now, if a patient presents with a goiter, which is an already enlarged, overactive thyroid, introducing a massive concentrated dose of topical iodine into their mucosal lining can trigger a severe systemic cascade.
Because the body just absorbs that excess iodine and the thyroid goes into absolute overdrive.
It precipitates a condition known as thyrotoxicosis.
Wow.
The sudden surge of thyroid hormones flooding the nervous system and cardiovascular system can cause dangerous cardiac arrhythmias and systemic toxicity.
So the physician examining your throat isn't just looking at the esophageal lining.
Not at all.
They must simultaneously manage the immediate physical mechanics of your airway, the chemical tolerance of your stomach lining, your immunological history, and the precise state of your thyroid gland before a single drop of this solution is deployed.
It's a lot to juggle.
It's a striking reminder of the cascading complexities of human anatomy.
It separates basic diagnostic application from true medical mastery. The physician must anticipate the systemic ripple effect of every single intervention.
Bringing this all together, what Dr. Raju's lecture reveals is the sheer elegance of medical ingenuity.
It really is elegant.
We are outmaneuvering a highly lethal, perfectly camouflaged cancer, not by overwhelming it with processing power or complex machinery, but by turning its own biological failure against it.
Exactly. We capitalize on the fundamental cellular truth that mutating squamous cells lose their glycogen reserves.
They lose their sponge.
Right. By introducing a simple, absorptive 19th century chemical stain, the healthy tissue is transformed into a dark canvas, forcing the dangerous, depleted cells to expose themselves.
It relies on a chemical compound older than the stethoscope to perform a task that modern imaging struggles to replicate.
It's a testament to the basics.
It really is. Thank you for joining us on this deep dive into the microscopic battlegrounds of the esophagus.
It is always a privilege to explore the remarkable mechanics behind these medical techniques with you.
We want to leave you with a final thought to mull over as you go about your day. We started this deep dive talking about searching for an invisible threat in a dark tunnel, and the solution turned out to be a rudimentary mixture of iodine and water interacting with basic cellular biology. It makes you wonder, as billions of dollars are poured into the pursuit of the next massive technological medical breakthrough, what other perfectly common everyday chemical compounds are sitting quietly on our shelves right now, just waiting for us to discover their hidden medical superpowers.